Okay, can you hear me now?
Yes.
Fantastic. So the best part about doing a presentation from so much far is that nobody can see me. That's the best thing. I don't know whether you guys can hear me or not, which is also not very bad actually. And the third thing is I can actually now cover up my face over here. So I can actually masquerade as someone else and somebody else can do this presentation for me. And the second best part about having this presentation today is that I will not bore you further. I have only one talk today. So you guys can aram say, detoxify me out of your system now. But since I have been given a job to say, and today is my talk is about updates in the management of small cell carcinoma lung. And small cell carcinoma lung, I can tell you coming low. That is predominantly because the smoking incidence, at least in Delhi, is coming a bit low, and more people are using more filter cigarettes, which are going and reaching more peripheral part of that. But what is more worrying is that the small cell lung cancer is a highly aggressive tumor with a 5-year survival of only 2%. I mean, that's the most your survival is not really increased over there. So why is it so? It is so because it's a fast growing tumor. It has got a high mitotic rate, scanty cytoplasm. It has got an early metastasis. I mean, when you see a patient of small cell lung cancer, you will have 72% of people who have distant disease diagnosis. People are normally elderly. They will have superior vena cava obstruction. They can have adrenal gland involvement. They'll have brain involvement. They have liver involvement. Only 2% of patients with small cell lung cancer are never smokers. And if we were analyzing our data in the last 5 years, I think I've just got some 15, 20 people who are non-smokers and have small cell lung cancer. And unfortunately, no target therapy exists for small cell lung cancer. And that is the most disappointing part of being treating a small cell lung cancer. So we spoke about the staging yesterday. Staging in small cell lung cancer can definitely follow the TNM system, but it doesn't follow actually. Staging in small cell lung cancer follows three systems. One, a limited stage. Second, an extensive stage. But for the students, there is something called the very limited stage also. So if you have one disease in the lung without any mediastinal lymph nodes, it's a very limited stage. If you have disease in the lung, which you can encompass in the radiation field, and you have some mediastinal lymph nodes, even with small effusion, that is a limited stage. But unfortunately, most of us will have a extensive stage small cell lung cancer, which basically means that it cannot, that the disease cannot be encompassed into one portal of radiotherapy. So that's the veterans lung group classification, which is a very, very useful classification. So very limited stage. If you have only small lesion, no lymph nodes, small lesion with lymph nodes, with effusion, it is called as limited stage, which can be encompassed into one single radiotherapy field. If you do not have that, if you can't encompass opposite side or adrenal, liver, then it is called as a extensive stage lung cancer. Now, the treatment is defined basically by limited stage or extensive stage. Now, I'll briefly just say on this slide about limited stage. So, if you have a limited stage small cell lung cancer, your treatment is either surgery followed by RT. I can count on my fingers how many patients have actually got surgery followed by RT or chemotherapy in our institute. It's one per year. And that too when the patient goes to surgeons first and he doesn't refer it to the radiation oncologist. Otherwise, generally we have RTCTs which are normally given for these people. But even in small cell lung cancer, the incidence is hardly, I would say 1 to 2 per month, not more than that people who undergo radiotherapy or concurrent CTRT. So the treatment for limited stage disease, CTRT followed by PCI. Treatment for extensive stage small cell lung cancer is basically a platinum-based chemotherapy, which we give 4 to 6 cycles. So I spoke about limited stage small cell lung cancer, and I'm sure Anjali is going to speak about the thoracic RT and the PCI in the next talk. So I'm not really concentrating much on small cell lung cancer limited stage. What I will concentrate is extensive stage small cell lung cancer. And the standard of treatment. So yesterday I told you when I was doing my DM, the easiest exam to pass was non-small cell carcinoma because you quote ECOG 1594, you give whatever, it doesn't make a difference. The even easier exam was to pass a case of small cell lung carcinoma because you say the past, present, and future was etoposide and carboplatin. The median approximate survival was 11 months, 5 years survival of approximate 0%, and there was hardly any long-term survivors. So people thought, yes, we should improve. How do we improve? We change the drug, we increase the drug, we give some maintenance therapy, we give some biological therapy. Unfortunately, all of them resulted in a big zero, and nothing really worked as far as improvement in survival was concerned. So one of the agents which was basically tried initially in the Japanese population, and remember yesterday when I showed you the NEG009 results in the EGFR mutant subgroup, I showed you, they had a survival of 52 months. Now Japanese are a different breed altogether. Japanese in CS stomach is different. The way they do their surgeries is different. The way S1 drug acts in them is different. Probably the way irinotecan also works in them is totally different. And this was a study which compared irinotecan cisplatin versus etoposide cisplatin, and the median survival here was 12.8 months way back in 2002. So this created a lot of hype and hope in the medical circles, and they basically thought that maybe finally we have something to go above etoposide and carboplatin. But unfortunately, so this was the irinotecan cisplatin versus etoposide cisplatin, which was basically shown in the study. Unfortunately, when this study was compared in the Western subgroup in the US with irinotecan cisplatin versus cisplatin etoposide, the trial by Hannah et al., which was presented in ASCO 2005, this is what exactly was the ECOG 1594 graph that we showed. It is what I call as a honeymooning graph. Everybody just even it's such a graph that even coronavirus cannot go through. The two lines, and there was no difference whatsoever. There was another trial which basically compared topotecan cisplatin versus etoposide cisplatin as a first-line therapy in patients of small cell lung cancer, and this trial also was a COVID graph. This is what kind of protection we want to develop while we had deal with corona. The overall survival did not change, so nothing actually changed. Etoposide cisplatin remained the standard of care for extensive disease small cell lung cancer. So they said, let's go for 3 drugs. Did not work. CAV was tried against etoposide cisplatin. Did not work. They said, okay, let's change the drug. Did not work. They said, okay, fine, maintenance therapy. So, whatever happened in non-small cell lung cancer also happened in small cell lung cancer. And they tried to give biologicals like interferons, marimostat, vaccination, VEGF EGR inhibition. But unfortunately, the one result was what Dr. Govind Babu gave me in the exam was a big zero. I'm sure Dr. Govind Babu will not like to accept this fact right now, but there was one exam and definitely I got a 0 out of that. There was only one exam in which he gave me a 0. I've got a zeros all over throughout, don't worry. But as far as the small cell lung cancer is concerned, it did not change anything, and the patient, the etoposide carboplatin basically remained the standard of the care. So this is what a summary slide of etoposide cisplatin in small cell lung cancer is. These people do respond very well to first-line chemotherapy with an overall response rate of 68 to 84%, with a median PFS of 6 months, a median OS of 10 months, but unfortunately a 5-year overall survival of only 2%. And that was a sad story of small cell lung cancer treatment. So the treatment of small cell lung cancer in one sentence could be described from 1988 to 2010 as the more the things change, the more they remain the same. Unfortunately, nothing happened. Etoposide cisplatin, etoposide carboplatin was the standard of care. So in the past decades, as we can see over here, from 1985 till 2017-18 probably, cisplatin etoposide ruled the roost. In second line treatment, you could give whatever you want, inotecan, docetaxel, topotecan, paclitaxel. Nothing used to make a difference. Only oral topotecan was the drug which was basically used to have slightly improvement survival. So there is definitely an unmet need as far as the treatment for efficacious treatment in small cell lung cancer is concerned. And if you can see this graph, this graph is a very important graph. From 1986 till 1999, when etoposide carboplatin came, there was a 8.3% improvement. But from 2000 and 2018, we can keep, there was hardly any improvement in the management of in the overall survival of patients with small cell lung cancer. And the overall survival was what probably what COVID is teaching us, and the way Indian people have managed COVID, that is dismal. So one word which could define the treatment of small cell lung cancer in by etoposide carboplatin is disappointing, and that's what. So this was a definitely a major challenge. And what small cell lung cancer actually needed was a bahubali. I mean, something immunotherapy or target therapy to carry them on their shoulders. And slight hint of that has actually come back in the last 2 years, when immunotherapy has now been tried in combination, initially alone and now in combination with chemotherapy in small cell lung cancer. So this was the pivotal trial. So there are four chemotherapeutic immunotherapeutic agents which have been tried. One is nivolumab, one is pembrolizumab, one is durvalumab, one is atezolizumab. So IM Power trial 133 trial is a pivotal trial of atezolizumab in small cell lung cancer. This basically compared atezolizumab plus etocarb for 4 cycles. Mind it, it's not 6 cycles, followed by maintenance therapy with atezolizumab, and the other arm was basically only chemotherapy with carboplatin etoposide. And this was the first trial actually in last 25 years to show a significant improvement with atezolizumab and chemotherapy. It was 12.3 versus 10.3 months. So remember, Japanese trial in way back in 2002, that had the similar advantage of 12.3 versus 10.3. But this here, the best part about immunotherapy now, and remember when I said 5-year overall survival was only 0%, now we could have 5-year survival of 4 to 5 or 10% in patients who had a small cell lung cancer also. So that's the benefit of immunotherapy, that maybe the response rates are low, but people who survive and people who survive beyond 6 months are the ones who might just do a bit more fantastic over here, with an HR of 0.70 and a median OS of 12.3 versus 10.3. This also resulted in increased PFS rate. Again, nothing great, nothing as great and fantastic as non-small cell lung cancer, but it's a start. After 25 years of absolutely no hope, it's a start. And I'm sure as we go ahead, we will have some more positive trials coming up in our way. The overall response rates was by and large similar between the two groups. Nothing great. So what atezolizumab probably is doing is it is trying to figure out those 10% of people who are late and long-term responders. So the response rate did not change, but there was definitely an OS advantage, as is typically seen in the immunotherapy trials actually. The subgroup analysis of OS also confirmed the benefit of adhesion and chemotherapy. And this forest plot shows everything was responding, whether you have a PDL1 positive, negative, whether you had a TMB high or low, whether you had a brain mets or no brain mets. Okay, people with brain mets did not really benefit from atezolizumab, but then this could have been a small subset of people which are there. Elderly people benefited a lot from in fact, if you see, more than 65 years of people did benefit a lot from immunotherapy and chemotherapy combination. So immunotherapy is not alone. Atezolizumab is not alone. In addition to atezolizumab, you have pembrolizumab, which was compared, and this was published in ASCO 2020. This was a oral abstract presentation and a virtual meeting over there. So this also compared the similar. So remember, in the IM Power 133, you had atezo plus etocarb, and now here you have pembro plus etocarb, which has coming over there. And this was the progression-free survival. Again, 4.5 versus 4.3 months. The p-value was significant, but the overall survival was definitely lesser than what was expected in the atezolizumab arm. This was significant, but this did not reach the level of pre-specified statistical significance which was there. Now, so we spoke about atezolizumab, we spoke about pembrolizumab. Atezolizumab definitely is, durvalumab definitely is. So this was a 9002 trial, which was a Caspian trial, which compared 3-arm study. So that's a very important study. They have a 3-arm study. The red one in the down is basically etoposide platinum, which we give it for 6 cycles. The one in with the dark blue is durvalumab plus EP, and the front one was durvalumab plus temilumab plus EP. Now, we would have definitely expected the first light blue arm to do much better than the dark blue arm. But unfortunately, when the final results came, this was not the thing. And in fact, if you see, the median overall survival was actually lesser with the durvalumab and the temilumab arm than what it was with the etoposide cisplatin arm. The final graph was basically said that the best results were found out by durvalumab and etoposide platinum, followed by only etoposide platinum, followed by durvalumab and temilumab and etoposide platinum. But that's the way the results are. So our combination IO is not going to work in patients who have got small extensive disease small cell lung cancer. Maybe a single agent immunotherapy plus chemotherapy is the way to go. So that's a summary slide, and that's a very important summary slide. This is the slide which has basically compared all the trials. So what I would like to tell you is that 2 trials on the left, that is the IM Power 133 and the Caspian D, are the ones which are the positive trials. We have an overall survival advantage 12.3 versus 13. Numerically, the highest advantage is seen in the durvalumab, that is the Caspian study. The PFS and the OS is better. The Caspian DD, the middle one, is a negative study, so there is absolutely no point in combining durvalumab and temilumab in a patient of etoposide cisplatin. Pembrolizumab, although it's a positive study, but this study did not meet the pre-specified statistical analysis, and the nivolumab study is a negative study. So, to summarize, treatment of extensive disease small cell lung cancer, you have 2 options. One is either pembrolizumab plus chemotherapy for 4 cycles, or you have durvalumab plus etoposide cisplatin for 4 cycles, and that is the way to go. However, these are the treatment guidelines for patients with extensive stage small cell lung cancer, and the combination is basically that they recommend either atezo or durvalumab with carbo and eto for the first line treatment of extensive stage small cell lung cancer. This is my light slide. This is the slide which summarizes the treatment of small cell lung cancer, which basically says, and this is one of my favorite slides, which says the woods are lovely, dark and deep, but you have promises to keep. And definitely, as thoracic oncologists, we have miles to go before we even think of hanging our boots and sleeping. Small cell lung cancer is a poor cousin of non-small cell lung cancer, but this deserves much more research and much more treatment than what is coming in its way. So with this, thank you, and I'll give you back to the organizers. Thank you.